Hi, and welcome to the show. Subscribe at kevinmd.com/podcast and get CME for this episode by clicking on the CME link in the show notes. Today, we welcome back Alan Lindemann. He's an obstetrics-gynecology physician. He's the author of the book, Pregnancy Your Way, Choose a Safe and Happy Birth. Today's KevinMD article is titled, U.S. Maternal Mortality Crisis, a Deep Dive. Alan, welcome back to the show.
Thanks a lot, Kevin. Happy to be here.
So Alan's been on multiple times. Go to kevinmd.com/podcast. In the upper right-hand corner, there's a search icon to look for his past episodes and hear his story. But today, let's talk about his most recent article about the U.S. maternal mortality crisis. Alan, how did this article come together?
Well, I've been interested in maternal mortality for a long time. As you know, I've delivered 6,000 babies and no maternal deaths, not even any eclampsia. So, yeah, I have a track record. I'm sure many other doctors have a track record that is that good. So I shouldn't be bragging too much, but I do know what I'm talking about. You know, back in 1980, we had a maternal mortality rate of approximately 8 per 100,000. And we reached a low of 7.2 back in 1987. But this has been going up and up over the last years. In 2019, the average rate in the United States was about 19. In 2020, it went up to 21. And as of 2021, it was 31.3. So, and that's an average rate. So, yeah, we're going up. If you look at other countries, you know, some people use the excuse that, oh, we just keep better records in other countries. I don't think so. But if you look at, say, for example, Japan, their maternal mortality rate is 2. If you look at Norway, Sweden, Denmark, you're talking about 2 or 3 per 100,000. So there's a lot of developed countries that do a better job than we do in this country.
Now, what are some hypotheses that can explain our rise in maternal mortality?
Well, you know, like I said, the most common one is we keep records better. Well, I don't think that goes real far. Another one is, oh, our population is getting older and we have more risk factors. And yes, if you look at the maternal mortality rate for moms 39 and over, it's 138. The problem with that is that there are not very many moms 39 and over who get pregnant. So we have other groups that account for that rising rate. As a matter of fact, I read an article in the Green Journal. This is from August of 23. So it's not very long ago. They set out to look at age as a determinant of maternal mortality. And that's one of the reasons or the excuses we use. We're getting older. Well, they set out to prove that that was true. And what they actually demonstrated was that it wasn't true. The maternal mortality rate was rising for every group, the 20 to 30, the 30 to 40, and over 40. So that alone doesn't account for what is happening to us. And of course, you also have a lot of people who talk about health. In other words, we have too many moms who smoke, too many moms who are overweight, too many moms with high blood pressure, all kinds of health excuses that, in other words, we're blaming people, we're blaming the patient. And the problem with blaming the patient is that it's not constructive. It doesn't fix anything. So yes, there are many so-called reasons for this happening.
Now, are there any demographic trends within that rise in mortality? Any socioeconomic factors that can explain those numbers?
Well, unfortunately, there are. And, you know, if you look at Caucasian white women, you're looking at about 20, 21 per 100,000. If you're looking at Native Americans and Native Alaskans, we now have risen to 45 per 100,000. And if you're looking at women of color, that has now risen to 69.9. I usually round it off to 70 per 100,000. So yes, we have remarkable socioeconomic and cultural disparities. And we do know that socioeconomic factors play. They have some influence as to how pregnancies turn out. I think partly that's because moms who, for example, if you have a job as a wait person and that's your only income and you don't have very good insurance and you don't have time off for pregnancy, you can't even get to your doctor's appointment. I think that that is one group of access problems. But I think there are other problems too. You know, if you look at, for example, NPR, and we've talked about this before, they talk about why they give it special or individual reasons. And I'm going to, if you think it's appropriate at this time, I can talk about one of those examples.
Sure.
Now, this has already been public, and the name is Johnson. Of course, there's a lot of Johnsons, but this was a lady of color. She went in for her second or her first repeat C-section. So that should have been a slam dunk. A repeat C-section is a very simple, straightforward surgery. Well, she had her surgery about 1 PM, and then about 4 PM, she was beginning to have pain and losing some of her color. So her husband went to the nurses and they were told that they would get a CT scan. Well, by 8 o'clock, there had been no CT scan, no doctor visit, and she wasn't scheduled for a return to the operating room. At midnight, they decided they would take her back to the operating room. And they said, it will be done in 15 minutes. Sometimes these things happen. Well, she died in the operating room. She had 2/3 of her blood volume in her abdomen. And that, of course, is not a good way to give general anesthesia because they collapse. So they tried to resuscitate her, but couldn't. So this lady, this is at Cedars-Sinai, by the way, so a good hospital. At 8 o'clock, when the husband went in again, I mean, before they took her to the operating room, the nurses said, "Mr. Johnson, your wife is not our priority right now." So this is really what happens. They're in the middle of all of this care, but they can't get at it. And, you know, if you're looking at death as the canary in the coal mine, for example, there's about 1,200 deaths in the United States per year, and that's come up from about 700 in the last few years. Well, this canary would have been dead for a long time because the real problem is the severe maternal morbidity. And they think that that is about 50,000 or 50 to 100 times more than an actual death. So we have a problem that's much bigger than it seems to be if we're just looking at maternal mortality.
So, what are some of the ways that you suggest that we can help tackle this worrisome trend?
Well, it is complicated. And, you know, if you just look at what happened to Mrs. Johnson, what needed to happen there was that the people who were taking care of her should have been bothered. They should have taken another 5 minutes to think, maybe she's telling us something important. And, you know, you can't tell nurses or doctors to think that, oh, you have to listen to everybody. I mean, that would be the advice I would give. Listen to your patients and take them very, very seriously, because, you know, it doesn't take long to walk into a room and to see that this lady has no red anyplace. Lips aren't red, her conjunctiva aren't red, that her belly's getting bigger, she's complaining. So we have to stop being dismissive. And if you look at all of the deaths, and there are many deaths that are recorded on NPR, if you look at them, it's the same problem. It's healthcare all over the place, but not the kind of healthcare that is doing people any good. If you look at this problem, it's not one problem. You know, they give the analogy sometimes of the airplane crash. It's not one system that fails. It's many systems that fail at the same time. And that's really what we have here. You know, if you got all the players in a room, for example, big pharma, Medicare, you know, Medicaid, several insurance companies, the AMA, a group of doctors and patients, if you got everybody in a room and tried to talk about symptoms or what could be done to solve this problem, everybody would have something different to say, and they would all blame everybody else. And that's really the main problem that we have right now. Nobody is taking responsibility for any of this. Now, we do have a grassroots movement, you know, like not smoking cigarettes in 1960. People thought we were kind of crazy for thinking in those terms, and this probably happened before you were born. But it didn't come from big tobacco. It didn't come from big government. It came from the people. And that's what's happening now. This movement is coming from the people. And unfortunately, it's because people are tired of it. They're hearing about it. They're thinking about it. You know, if you look at, for example, ACOG, that's the American College of Obstetricians and Gynecologists, they have the opportunity to take leadership here, but they're not. Medicare has the same thing. Now, they've recently come out with $168 million. They've named 9 centers of excellence. And their centers of excellence include mostly data gathering. And that's one of the things that our government does best, is gathering useless information. But even if you think they could gather something useful, it's going to take 7 or 8 years to get any results from that. So we really need to start thinking right away. And unfortunately, like I said, this is probably going to be grassroots. You know, access, that could be something that Biden fixes tomorrow with a stroke of a pen. We could talk about, you know, our legislators helping out. We could ask ACOG, you know, well, where are they in this maternal mortality thing? So, but we're not doing those things. So it's going to be grassroots.
Now, if you were in charge of policy, if you were in charge of ACOG or could make decisions on behalf of our government, what would you like to see them do?
Well, first of all, they need to come out and say, we think this is a problem. We are going to take this very seriously, and these are the things we're going to do. For example, everybody is going to have access to prenatal care, all of the prenatal care we need. We are not going to deprive any patients of visits. You know, one of the problems we have right now is we have limits on the amount of visits you can get. And I think one of the reasons I had 6,000 births with no maternal mortality is that I didn't pay. I had my own practice. So if I didn't get paid for a visit, it wasn't a problem. You know, I was just the only one that had to worry about that. But yes, we have doctors now who have to worry about getting paid because a lot of them are unemployed, or they're employed doctors, I'm sorry. So their bosses are kind of looking over things. So access, I really would improve access. The other thing I would do is make sure that everybody had all the care they needed up through the first year. You know, in this country, we shut off prenatal or postpartum care at 6 weeks. That's because the uterus takes that much time to return to normal size. I saw my patients as often as they needed to be seen. A week, that was my favorite time to see them, because that's the time you can head off troubles. And of course, they need, anytime somebody comes in with a complaint like bleeding, they have to be seen right away. We should have absolutely no deaths from bleeding in our country. So bleeding things, nobody should bleed to death. Let's see, one of the things that I tried to do 30 years ago was to make sure that moms didn't have mental health problems, moms and dads. And to that end, I saw everybody, that is, moms, dads, kids, were welcome at every visit. And I think that's really important because you get to see how the family reacts, how they interact with each other, who's the boss, how do they respect each other, do they like each other, do they love each other, can they work together. If you take the number one cause of maternal mortality today, and it's called behavioral. So suicide, homicide, and drug overdose are in that group. Well, I think that is preventable. Now, I know people are going to call me a heretic for saying that, but it's preventable. And for the people who fall through the cracks, they have to be seen immediately the day they call, and they have to be seen. They need treatment. A lot of them, you have to listen to them. I always had a psychiatrist I could call, so we talked about what kind of meds to give. I liked Ativan and Effexor because the Ativan worked right away and the Effexor worked really well. And then they'd see the psychiatrist within the week. So, there's a lot of doctors now who don't think that behavioral even falls within their purview. And yes, they can say that, but it doesn't fix the problem. We still have the problem, and we still have the opportunity to fix it. So if I could wave a magic wand and fix things, I would fix prenatal care and postpartum care.
We're talking to Alan Lindemann. He's an obstetrics-gynecology physician. He's the author of the book, Pregnancy Your Way, Choose a Safe and Happy Birth. Today's KevinMD article is titled, U.S. Maternal Mortality Crisis, a Deep Dive. Alan, let's end off with some of your take-home messages that you want to leave with the KevinMD audience.
Well, thank you, Kevin. I think that, one of the reasons we wrote our book is because of what I was talking about as far as mental health during pregnancy. So mental health during pregnancy is not mysterious. It's not magical. It's not complicated, but you have to care about it. Everybody has to care about it. Years ago, we could keep moms and dads and babies in the hospital as long as we wanted after birth. Today, they're kicked out after 24 hours. If I could wave a magic wand, I'd fix that. I'd say, keep them in the hospital like we used to until they're ready to go home. They need to know what to do when they go home, how often to feed the baby, when is it hungry, who should do the dishes, who should fix the food, clean the bathroom, wash the floors. These are the things that people have trouble with when they go home. So if they had a plan, they'd do better.
Alan, thank you once again for sharing your perspective, time, and insight. And thanks again for coming back on the show.
Thank you, Kevin.